Hello, this is the front desk.
Good morning and welcome to another episode of the Crack and Backs podcast with your hosts, Dr. Terry Wyman and Dr. Spencer Barron. How you doing this morning, guys?
Doing good, Lance, buddy.
Great, Lance. Great.
That's great to hear. So today we are joined by Dr. Bert Mandelbaum. Dr. Mandelbaum is among the world's foremost experts in the diagnosis and treatment of orthopedic conditions, especially those related to the knee. He practices at and serves as co-chair of medical affairs at the Sinai Kerlan-Jobe Institute in Santa Monica, California. How you doing this morning, Dr. Mandelbaum?
Great to be here. Thank you.
Hey, buddy. Yeah,
It's great
thanks
to hear.
for taking the time. I know you're really busy squeezing us in between surgeries, post-op, and all that kind of stuff. You also just got back from Qatar, and you're leaving in just a couple of weeks to go back for the World Cup. I've been hearing a lot about Qatar, from F1 to Formula. What's it like over there, and how's things changing with the travel thing?
Well, first off, Qatar is ready for the World Cup. It's an unusual situation. Small country, 20 miles from venue, stadium to venue. There's 10 of them, and they're prepared. It's a small Middle East nation. Done a very good job of preparations. The bricks and mortar, and grass are all in play. Players have their plane tickets. The grass is green. The whistles are out. The referees are there. Time for a World Cup.
How do you think we're gonna do?
We're gonna do great. We're gonna do great. I have an open ticket to come home. But it's gonna be delayed well into December, which is good. Which indicates that we're gonna do well.
Nice. All right, since you're busy, I want to dive into some cool topics that you love, especially with the knees. And one thing I loved about you, you're always like ahead of the curve, which is what this kind of show is about. And back in the early 90s, you had a protocol called PEP, which is kind of funny since we work at Pepperdine, but it's called PEP. And it's talked about avoiding knee surgeries, especially those with the ACL. And can you talk about how you came across that as a surgeon to avoid the surgery, and then how that protocol has evolved to where it is today?
That's fascinating. In order to answer that question, Terry and Spencer, you have to understand my background. Everything I know is about sports. I grew up as an athlete. I was a football, then lacrosse player. I coached lacrosse at Johns Hopkins for 2 years. Went to medical school. Only thought of myself as an orthopedic doctor. So I've always been interested. It starts with sports, ends with sports, and that's what I do. I was practicing as an orthopedic surgeon in the 90s and found an amazing trend here in Southern California where all of a sudden my practice was basically 70 or 80% male. And all of a sudden, about year 1999, it became 70-80% female. Began these young female, 14 to 18, having a variety of non-contact injured ligament injuries. We got together with a group of trainers, athletic physicians, chiropractors, put together a whole approach of why this was happening. We reviewed videotapes, and we came out to think that in reality the cause was a dynamic instability, neuromuscular abnormality. And ultimately we decided we would do something about it by making a prevention program. Prevention program acronym, as you said, is the PEP. Prevent Injury, Enhance Performance. Not Pepperdine, but Prevent Injury, Enhance Performance. We wanted to get it sound more athletic. It's a warm up, beginning of sport. Ultimately, we found it was effective. We could prevent ACLs by over 80% here in Southern California. The CDC, Centers for Disease Control, got wind of it. They decided we would do a big randomized trial, NCAA, female athletes, and we found that we could reduce injury by 72%. FIFA, Federation of International Football Association got wind of it. We transformed it to the FIFA 11 Plus program, translated to 11 different languages, and now it's a global prevention program with our most recent study showing a 76% reduction in ACL injuries in male athletes. So it's been an evolution, but it all starts with my interest in the athlete. Yes, I'm a surgeon, and that's part of my job. But I also have to think about young kids, sports prevention, and again, we all remember in sports medicine that we're interested in the trilogy. It's about performance, it's about prevention, and it's about injury care. And I think that's how we think of that trilogy, and this is just part of that.
Are you noticing a trend to now? You obviously noticed the trend amongst females having ACL, but have you noticed it happening to younger kids because of how parents are having their kids compete in one sport, one activity perennially now? Do you notice a difference?
We're seeing a rise in ACL injuries at all ages, from 10-year-olds to 14-year-olds to 18-year-olds. And it also goes in waves. I have found. I've been at it a long time. I'm talking about the 90s. So we're talking over 20 years. And in these 20 years, we've seen areas that would peak and decrease and then peak again. And I think what that relates to is the vigilance that we now develop the prevention program, the vigilance that the medical coach community really ensure that we do prevention for a while. It gets old. They start focusing on goals and winning, and then the trend goes back up again. So yes, it's increasing, but it increases in cluster over time in a wave form.
Why soccer? Did you get scooped up because soccer sees the most ACLs, or was it just by chance?
It's by chance. My career started at UCLA. Team physician when I came in. Obviously, UCLA, big football, big basketball. A young guy comes in there. You got the soccer team. And I hated soccer. I was a football player and a lacrosse player. I hated soccer for a couple of months. But all of a sudden, I came to love soccer. We won the national championship my first year. And God bless him. Ziggy Schmidt, rest in peace, was a coach at the time, and asked me because he was involved with some of the national teams. Said, "Why don't you get involved in national teams?" I did with the youth teams, and then the World Cup came up in '94. I applied for the job. I got it. I've been there ever since. So it's a short but long story.
No, that's great. That's great. By the way, I do have to mention, if you ever want to be a commentator, your original description of the landscape out in Qatar, I was actually fascinated. You sounded like either a travel agent or someone, because I almost wanted to go after you started talking about it.
Especially the grass.
There's still seats available.
It's amazing they took this island and they turned it into this little paradise. It's amazing what oil money can do, right?
It's gas. And it's
natural gas.
a peninsula, not an island. So it's fascinating what they can do in the Desert Kingdom. But it's also fascinating that the royal families there have really created a focus on excellence, on sport. And there they have a major academy, which is a model for the world. It's called the Aspire Zone, which is a focus on sports. And many of the things we're talking about, they have a sports medicine center there called Qatar. We collaborate with. And last week was a keynote speaker there for their basically the World Cup meeting. But it's a series of professionals, scientists, physicians, all focused on all aspects of athletic care. So fantastic model, and they're firmly committed to care there. It's impressive.
Oh, so great.
So we're talking about athletes, and they're younger and more subtle, they're more flexible, and yet most of our listeners are 50 and over. And so I know one of your passions from what Dr. Terry was telling me that helping the older athlete, and how does that look for us? What would that look like in how your management?
First up, Spencer, I don't call it older athlete. I call it seasoned athlete. Experienced athlete, conditioned
I like
athlete.
that. That's great.
So what happens to the group who played sports like myself and others is we get arthritis. And this has been an old phenomena. The first team physician was a fellow from 100 AD in Rome, Claudius Galen, who said athletes live longer and they don't live shorter and they get arthritis. And today it's the same thing. And we've got to reverse that trend and keep the joints functioning well. We have a variety of solutions. We have joint preservation. We have a whole family of orthobiologics. And then when all that doesn't work and get to the end of the road, we have great joint replacement protocols that are being done with robots and all kinds of high-tech devices. So there's a lot of hope for the seasoned athlete.
Right. I'm going with the seasoned look. Thank you.
There you go. Welcome to the category.
Yeah, right. But let me understand. I know that the history of ACL repair, I believe, started like 1895, or was the first reconstruction or repair or something. But
1903.
Is it 1903? Now, what's the difference between a repair and a reconstruction for the listeners that are curious?
Well, repair is ACL tears. Basically somewhere between the mid portion and some portion right above it before it connects into the femur. And we have been wrestling with the concept of putting sutures in this, putting it together, and having well, that's really difficult to do over time. So we need to supplement those kind of things. In recent years, there's been a what we call the BARE, biologic bridge and hand repair. Which is for ACL reconstruction, and it's been an interesting thing. Martha Murray in Boston has piloted this, done the basic research, clinical research. The problem that we have with repair is that instead of 6% of re-tears that they had with the reconstruction, they have 14%. For us, that's much too high when we're dealing with athletes. So it's not ready for prime time yet. We've got to do more. We've got to do more innovation, improve it. It's like a lot of things. Innovation takes steps, and this is one of those steps. Reconstruction is when you take a graft. And you put the graft as a bridge between the two bones that stabilize the bones, most often using the patellar tendon, quadricep tendon, and sometimes the hamstring, and sometimes the cadaver graft, depending on age of the patient. So these are all the options. Grafting techniques, reconstructions have lower re-injury rate. At the end of the day, that's what we're interested in. That's the most important metric that we have in terms of getting our athletes back to sport.
Actually, you bring up a good point, and I would like to elaborate on that because when I worked for Miami Dolphins, ACL injuries were plentiful, and there was always that choice between an autograft or allograft, or whether they use hamstring tendon or patellar tendon for the repair. Do you have maybe a kind of a guideline or a thought based on how you choose which to use?
I think historically over the last 25 years, the patellar tendon has been the major graft that has gotten back athletes in a very durable way. So the NFL, soccer players, that has been, if you will, the gold standard over time. In the last 10 years, it's been innovative. Quadricep, sister tendon, has also been innovative. Similar properties. Is also durable. Performs at the same rate. That's about the same re-injury rate. But doesn't have any of the graft harvest. So it's become really popular these days. And in 2022, the trend towards quadricep has been much more significant. And a wide spectrum of athletes will use that. But again, patellar tendon and the quadricep tendon are great choices in dealing with the athletic population.
We used to hear a lot about the hamstring tendon. Yeah, is that being kind of pulled away from a little bit now?
Well, the hamstring tendon had the problem with it over time. Doesn't have the same rate of re-rupture. It's higher. And a lot of that has to do with the same principles we spoke about in terms of our prevention program. Hamstrings keep the tibia in a position and help the ACL from not being torn. If you take that and become weaker by virtue of that, then you potentiate the probability of re-injury and having the same dynamic valgus. So it kind of goes into the wind rather than is parallel with the wind. And in that regard, we've come away with that. We've got to do all kinds when we do hamstring. You have to do another procedure, an anterolateral ligament to be at the same rate. So it's more complicated in that regard. And so the trend is for patellar tendon, quadricep tendon.
Love that. Love the fact that you gave a perfectly biomechanically sensible reason to prefer quadricep instead of hamstring because of the way that it supports the ACL, the hamstring. So that's fantastic.
At the end of the day, my goal is to reduce ACL injuries. And even after I do surgery, my goal is to minimize the rate of re-rupture. I'm not zero, but I always say it's my goal. You know, and I shoot for that in everything I do. You know, we try to biologically augment our grafts, PRP in our grafts. Everything we do, we have a very elaborate return to sport program with Dr. Chris Powers, who is a guru from USC, who's helped focus on return to play, mechanical, biomechanical intactness. So each of these features are really important. When it comes down to anything involved with the ACL, you're only as strong as your weakest link.
And the preference, your preference to either a cadaver or artificial or a tendon, hamstring or quad. Well, in this case, do you have a preference in how you would select which to go into for that patient? Which of the options?
Quadricep tendon. I use both of them. And you have to use both of them because you have re-injuries. Patellar tendon, you have quadricep tendon, and vice versa. So I think today to be a good surgeon, you have to have a lot in your abilities and capabilities. So I think they're both great. And if listeners are going to have a patellar tendon, it's a great option. Highly recommend it. If you're going to have a quadricep, highly recommend it. So it's really like they're very similar. Have some mild differences. People will select one over another. But they're really the top choice today.
Yeah, we had a case of a running back, a Super Bowl running back that was in the Super Bowl for the Denver Broncos, and he ended up with an ACL, and he ended up getting a weave of a hamstring tendon and a I don't think it was cadaver, it was the artificial, they braided it and used that. I never heard of that. Is that something that's
we don't do that anymore. That was an older concept. We're away from synthetic ligaments at this point.
Good, because the problem was that he rejected the synthetic and ended up having to get the reconstruction again, and he ended up not going back to play. He actually developed an infection. The knee swelled up, and he was on a PICC line for a month. So, yeah, glad that you're preferring.
But in discussion between two graphs, it's kind of like discussion whether Kobe Bryant is better than LeBron James. So you can argue all day long, or back in your day, or Mickey Mantle. choose the sports argument better. The same thing for aquatic intelligence.
That was great. That was great. But remember, I'm a seasoned athlete, right?
Commenting.
A very seasoned athlete. Over seasoned.
Oh gosh! All right. So, how do older athletes, seasoned athletes, what do they need to do and to save their knees? Any thoughts? Because I know you're big on prevention too.
Well, the first thing I say is that and people who know me well, if you could walk and not sit, you walk. If you could run and not walk, you run. If you can climb and not walk, you climb. So there's a principle here that at every level we need to continue our activity at the next level. And as we age, I think these principles become really important. Training, if you evaluate a group of dectogenarians, people live to 100, you find the one common principle between all these folks is exercise. And exercise at the highest level. And it's high level. When I say highest level, you can do in your 70s, 80s, 90s. And so that's the one principle, the one thread between all those folks that you have. So exercise is important. Diversify exercise in terms of things in the water, paddling, swimming, walking, hiking, doing elliptical, yoga, Pilates. Choose what you like. Do it. Diversify it. Practice it. And do more of it as you get older. Is the key thing. And commit on a daily basis.
Oh, that's great. There was a paper published, I want to say it was about 6 or 7 years ago, and it was regarding how, I know you're involved. You're more likely than most surgeons to prefer prevention and good, post-op care, but the paper described how physical therapy oftentimes can curb the potential for an ACL injury, and the study that was done qualified and quantified that. And yet it was kind of, again, I think the paper was, if I recall, was done by physical therapists, and yet they found that there was such a large number of ACL surgeries still being done, and the reason why is because insurance covers it, instead of a good round of physical therapy, which I'm not sure. Any comments on how you feel about
first off,
prehab?
ACL injury is not a binary issue. It's not when you have an ACL tear or not. There's a wide spectrum of ACL injuries. And then you superimpose on, for example, a low small injury in a high level athlete is not a good thing. And sometimes a big ACL injury in a low level athlete is not a problem. You can treat non-operatively. So it's not one size fits all. It's a spectrum of issues, spectrum of tears, a spectrum of athletes. And there's no question in a group of athletes rehabilitate non-operative programs work. But when it comes to soccer, basketball, tennis, skiers, it's rare that you can find a situation where you treat them non-operatively, simply just because it's an important cable keeping the two parts of the lower extremity together. If you don't have that, it's like having bindings. Can you ski with your bindings? Sure you can. But at some point, it's going to pop out of the binding. So it's a mechanical issue, and I think there's a lot of misunderstandings, biases in all directions. And I think the key, I tell people, it's a non-binary issue. You have to understand the specificities of this. And the key issue is what is going on in that particular patient, that particular time, and what are their goals and objectives.
You bring up also some good points, and people are so. Sometimes they don't look at what they do for a living. They just want that quick fix, especially this day and age. Everybody wants that quick, I got to get back tomorrow fix. And so they're looking at restoration stuff like PRP and stem cells. What's some of your thoughts on the restoration of especially the knee joint. And barring from our conversation the other night, let's take the MMA guys out because they're mixing the DMSO and and the stem cells. But what's your thought on the restoration and where that's going?
Well, I think the whole regenerative field is in a rapid evolution of new concepts, new techniques, and new technology. And like any rapid innovation curve, you have to go through steps. A lot of it can be hyperbole in marketing, and a lot of it has merit. It's hard to ferret out the difference between either and both. So that's one of my areas to focus on, is to be right on that line and find out what's effective and what is an exploitation of the gap between hope and knowledge. We talk about stem cells, but there are very few things that have real stem cells in them that are given to patients. So we have to be realistic, and we have to understand the context, specificity, and the details, and be aware not to exploit the gap between hope and knowledge. And we're at that stage. We're just figuring it out. It's evolving. We're not at the tipping point. So we have some more steps to go up. It's evolving quickly. It's exciting. Great opportunities. And we're certainly in the mainstream of this frontier. But we're not there to say all things for all people at all times. We've got to get much more specific and granular as we go forward.
Spencer and I so agree with all that kind of thought process, and the thing that that I love about you, Bert, is you're always not only looking at the science and looking for the knowledge, but you look elsewhere to gain knowledge from different. You get inspiration from a lot of things, even from nature, and we all live by the beach. We all, some of us go in the water more than others. Some are afraid of the water when it gets dark. But you bring up a lot of...
You had to go personal.
I had to. You go a lot of inspiration from the ocean. In fact, it's a little known secret that you love sharks. And you have a fascination with sharks, but you like looking at sharks for a different reason other than they're big and they have a TV show called Shark Week. You look for them for like cartilage and how they work. So can you talk about your love of sharks and where you pull some inspiration from them?
Well, most people don't know that I was focused on biology, marine biology, youth and college student, and had a 6-year ocean lifeguard, and spent in the East Coast though. In the East Coast, different in California, is one half your days are clouds of rain, and so you have a lot of time to play in the ocean yourself. And I really developed my love for the ocean then, diving and watching the ecosystem off the beach, and had a fascination with sharks from a very young age. And I still do. If people know me and they've seen my videos with some great white sharks off Guadalupe Island in South Africa, and see me dive at Tiger Beach in the Bahamas. That's one of my fascinations and passions and hobbies that I love doing. So that's something I just have grown up doing. Part of me.
What have you learned from sharks and relate it to your knees and studies on the human body?
Other than the fact that we have this incredible ecosystem that God provided us in this what we call Earth, and everything exists for everything. You've got massive predators like sharks, and you've got everything in the lineage of in the ocean to feed the small fish, to feed the bigger fish. And how important it is to have symbiosis balance of the ocean, and have tremendous respect for our environment. Everything from understanding runoff to global warming, and how important it is to manage these things to the degree that we can. But for me, it gives me incredible respect and awe of how magnificent our ecosystem, our Earth is. With that in mind, they're going to chop my head off. I've got to go to clinic. This is like a quick exit. They keep on sticking their head
buzzing
in the roof, and they say, gotta go. So unfortunately,
Thank you for listening to today's episode of the Crackin' Backs podcast. We hope you enjoyed, and make sure you follow our Instagram at Crackin' Backs Podcast. Catch new episodes every Monday. See you next time.